Good afternoon, everyone, and welcome to the GLPP HIIN and Minnesota HIIN Sustainability Webinar Series. A few housekeeping announcements before we get started with the presentation. All lines will be muted. For those of you using PC audio, we ask that you please mute your lines throughout the presentation due to additional noise feedback that may occur. Throughout the discussion and during the Q&A portion, feel free to use the questions panel on the right side of your screen. Additionally, this session will be recorded and we'll post the recording and slides on the MHA community site. If you have any additional questions outside of the webinar, please email keystone@mha.org. With that said, it is my pleasure to hand it over to Jenny Schonecker from the Minnesota Hospital Association to start off today's presentation.
Great, thank you so much for the introduction. Hello everyone, Jenny Schonecker from the Minnesota Hospital Association. I'm the Senior Director of Quality and Safety, and I'm happy to be here today to talk a little bit about the sepsis work of the Minnesota Hospital Association. So today I'll be providing you with an overview of the sepsis work the Minnesota Hospital Association has been working on. The overview will include a review of sepsis data, the MHA Sepsis Committee Work Plan, as well as a couple of our specific quality improvement initiatives around sepsis, which include the Sepsis Roadmap and Sepsis Site Visits. So a quick data overview for you. This measure is sepsis all-cause mortality. You can see 116 out of 120 hospitals reported a 20% reduction. And we did see a lot of variation in this measure, but ultimately over time saw a slow decline leading us to meeting that reduction goal. The next measure is the ARC PSI 13 claims measure. We had 83 of 119 hospitals report a 15.63% decrease from baseline. And this, you can see, was a little more steady decrease over time. So I'll take some time now just to go over some of the improvement initiatives in place to improve sepsis outcomes. The Minnesota Hospital Association has many quality and safety committees, which are made up of hospital and health system representatives from across each state, or from across our state, and each committee has a work plan that is followed throughout the year. And the Sepsis Committee's work plan priorities include increasing implementation and adherence to the Sepsis Roadmap, as well as performing sepsis site visits, outreach, and education. So I'll go over both of these work plan priorities in a little more detail. And I'll start with the MHA Sepsis Roadmap that you can see here on your screen in red. The MHA Sepsis Roadmap provides hospitals and health systems with evidence-based best practice recommendations and standards which are intended to align process improvements with outcome data. And the roadmap reflects published literature and guidance from relevant professional organizations and regulatory agencies, as well as identified proven practices. The MHA Sepsis Committee provides expert guidance and oversight to the roadmap. And accompanying the roadmap is a sepsis toolkit, which includes posters, an algorithm, order bundles for both the ED and inpatient care setting, as well as tools for sepsis simulation, detection, and screening. And then we also include past webinar recordings and videos on sepsis. The sepsis roadmap itself is made up of about a dozen different elements. I'll go over the fundamental elements within the roadmap. I'll just read them off for you here. The first is a physician or advanced practice provider is designated to lead sepsis performance improvement efforts. Another element is that sepsis care champions are promoted and recognized by the organization. And routine sepsis screening is performed in the ED and inpatient unit based on SIRS criteria. That there is a standardized order set in the ED and inpatient unit for early detection and treatment of sepsis and septic shock, that incorporates the Surviving Sepsis campaign 3 and 6 hour bundles. And for patients with sepsis or septic shock, evidence-based guidelines are in place that indicate when to transfer to a higher level of care. Tracking and monthly review of sepsis incidence and mortality rates and process measures, and a monthly review of compliance with routine sepsis screening and rapid treatment according to Surviving Sepsis Campaign 3 and 6 hour bundles, which includes documentation of time zero and use of a sepsis order set. So those are the fundamental elements within the sepsis roadmap that the sepsis committee oversees and manages. All right, let me try and advance the slides here. There we go. So the sepsis roadmap itself includes the elements that I just reviewed, and those are tiered into fundamental and advanced. So the fundamentals are your more basic strategies for quality improvement, whereas your advanced are what you'd want to start focusing on after you've been able to implement and sustain your fundamental elements. The roadmap is organized into sections to address specific aspects of care. You can see on the screen here, the section we have highlighted is the facility's core strategies for the early detection and treatment of sepsis and septic shock. The document is in audit style format, so it's designed for use as an auditing tool, which can then be a working document for quality improvement. Also included in the roadmap are operational definitions to give additional information to ensure all hospitals are interpreting them the same way. And it also assists facility team members with roadmap auditing and identifying whether current work meets the intention behind each of the roadmap elements. And then there's also line-by-line references and resources that are linked within the roadmap. The resources include journal articles or expert recommendations, electronic order sets, and other tools which organizations may use to assist in implementation of best practices. So here you see what the roadmap looks like in the MHA data portal. And the portal is an interactive module with both tracks, fundamental and advanced. And then there's also operational definitions, which give users that additional information to determine whether or not they feel they meet the intent of each recommendation. So you can see on your screen the little eye. When you're in the portal and you hover over that, you'll see that operational definition. And then staff can attest whether they have implemented each of the elements. And from there, they can create an action plan for next step. And then they can also access the different resources or links within the portal as well. And then when they're completed filling out the roadmap, they can print out a PDF of it to either email or print and share with their team members, and can be used as a working document. So what you see on your screen is the data from all the hospitals that have completed the sepsis roadmap in the data portal. So you can see that of the 83 hospitals that completed the sepsis roadmap in the online portal, 84% of them report adhering to the roadmap elements. And each of the bars represent an element of the roadmap. The blue are the fundamental elements and the green are the advanced. So you can see one of the higher performing elements is the routine sepsis screening. So 94% of hospitals in Minnesota that completed the roadmap in our data portal report that they are routinely screening for sepsis. You can also see that one of our lower adhered to elements is in green, that 8% are reporting that they provide literature to patients in the clinic to increase public awareness of sepsis. So as a state, this gives us a really good view of where we need to spend more time on our quality improvement initiatives. So we may want to, as a sepsis committee, decide that we want to make that 8% improvement goal, and we want to work on how can we provide different tools or education or resources to support the improvement of providing literature to patients in the clinic setting, for example. So this gives us a really good view at the statewide level of how we're doing within the different elements that our varying committees recommend we follow. Next, I'll talk a little bit about the sepsis site visits that we have been performing for the last couple of years. The sepsis site visits are offered to organizations that are looking for input into their sepsis program, and it's focused on their specific needs or questions. So a 2 to 3 hour site visit is scheduled with the sepsis committee chair and MHA staff, as well as the hospital sepsis team. So prior to the visit, there's a site visit checklist that's completed. It outlines the process and the different information that is going to be reviewed during the visit. And then a prep call is typically scheduled a few weeks ahead of time to ensure a productive visit and making sure to address the hospital's needs. So prior to the call, the hospital is sent an assessment form that asks questions related to their varying sepsis goals, barriers, challenges, priorities, or needs. And then the assessment is reviewed during the call and information is gathered to tailor the visit for each hospital. Another thing is that's reviewed is the sepsis roadmap, and the sepsis subject matter expert, who is also the sepsis committee chair, reviews that roadmap, each element with the sepsis team at the hospital, and talks through either the process or programs they have in place that have led them to be able to implement that element, or the potential challenges or barriers for why the element may not be implemented. And then there's discussion around how can you make some different improvement initiatives work for your facility to hopefully be able to answer yes to the varying elements within the roadmap. And then there's also some data analysis that is completed at the site visit as well. We use comparison data reports, and I'll show you a couple of those as well, what those look like. So we've completed about 15 sepsis site visits over the last couple of years. Like I said, the committee chair of the sepsis committee and the quality and patient safety staff from the Hospital Association meet with hospital sepsis teams, which includes the emergency department, inpatient physicians, nursing staff, and quality and safety leaders. And these offer the opportunity to hear and learn the latest in evidence-based best practices. They learn valuable information of what others are doing to advance sepsis care. And then there's opportunity to ask questions related to their special interests or needs. A couple of these sepsis site visits have resulted in a follow-up grand rounds, which is offered by the subject matter expert to the hospital's clinical staff. So I mentioned that the hospital's roadmap is reviewed during that site visit as well. So the subject matter experts goes through each line of the roadmap, and then there's really great discussion around what has the hospital been able to do to be able to implement the different elements within the roadmap, and potentially what are the opportunities to address different barriers that have had an impact on not being able to follow those best practices. And then here is an example of the comparison report. So the hospitals in Minnesota have agreed to have these comparisons reports for each measure, which shows each facility's name and where they sit in their outcome measures. So you can see here that for the sepsis all-cause inpatient mortality, this specific image is showing only those PPS hospitals, prospective payment system hospitals, and you can see that those above the green line are above the HIIN goal, and those below are below where we want that goal to be. So this is a good way for hospitals to see where they sit in comparison to their peers, and also gives them the opportunity to reach out to a high performer if they want to learn more about the work that organization is doing to have the outcomes that they have. And this is just another view of that comparison report. They can see where they sit compared to the rest of their peers, as well as compared to the state rate, the critical access hospital rate, the PPS rate, and then that HIIN goal. So all of the MHA sepsis resources are on our website. You can access them through the quality and safety page of the Minnesota Hospital Association website. And there's links here as well in case you want to go directly to the sepsis roadmap or any of the sepsis resources. And of course, if you have any questions or feedback about the sepsis work, you can reach out to myself or Tracy Radke, who leads the sepsis committee, and we can point you in the right direction to get you to any of the resources you may be looking for, or questions you might have. And with that, I am going to turn it over to Josh Swire from the Michigan Health and Hospital Association to talk about the efforts in place in Michigan.
All right, thanks, Jenny, appreciate it. So to begin, I wanted to do a quick overview of the GLPP HIIN improvement data in terms of the two primary metrics, one being sepsis mortality and the second is being post-op sepsis. Let's see if I can get this next slide over. Okay, so as you can see, across our states, we've successfully decreased sepsis and septic shock mortality rates by 7.1% and the incidence of post-operative sepsis by 5.1%. And that is just such a fantastic feat. Well done to all of you change agents and organizations that made this possible. You know, the content presented in this webinar are truly meant to highlight some of the resources that you may have used to accomplish these outcomes, but also provide you with some new tools. So we hope you continue to utilize these resources to sustain your improvement and continue to drive process changes in your organization. Okay, so let me kick off some of the good work we've done here in Michigan and across the HIIN. I'm going to be discussing 4 topics today. The first 2 are surrounding sepsis program development, which is the sepsis practice collaborative model and the sepsis best practice diagram. And then I'm going to go through sepsis process improvement discovery tool, which is a chart review system that you can use to identify gaps. And then lastly, I'm going to go through some of the sepsis simulations that we've done over the past 3 years, which were events that provided direct hands-on sepsis care in a controlled simulation lab. Okay, so the sepsis practice collaborative model was created recently, actually the middle of 2019, and it was in association with Vlasic and Roth firm. And the whole point of this model is truly to provide a high-level overview of sepsis fundamentals, and it's very visual. It was created for either the new sepsis coordinator or an existing sepsis coordinator that is looking at understanding their current sepsis processes and perhaps wanting to improve upon them. So it's really like that 20,000 foot view of what are the absolute basic sepsis fundamentals that we need to have in our organization. It goes all the way from, establishing a team and a steering committee to the implementation of the bundles. And actually here on this next slide, this is the first page of that sepsis practice collaborative model. And as you can see, it's split up into 4 strategic tiers. The first tier is organizational support, and it recognizes that, we must align sepsis program goals with organizational priorities. Resources must be allocated to build a successful evidence-based program. It also discusses developing a sepsis team to steer improvement that meets once to twice a week, identifying a sepsis coordinator to oversee the program. Prior to my work here at the MHA Keystone Center, I did work as a nurse, and I was a sepsis coordinator in an acute care hospital. So recognizing that organizational support is very important. The second tier is outlining the early screening, and we know that approximately 85% of sepsis cases enter through the ED. So the appropriate and early recognition of sepsis is truly a prerequisite for starting those therapy bundles. And this collaborative model stresses the importance of performing routine screenings at multiple points of care, whether that's upon entrance into the emergency department, transfer to the ICU, on admission, every shift, etc. So this is another snippet of a slide in the collaborative model. And as you can see, it's very basic. This is challenging an organization to ask themselves 3 simple questions in terms of blood culture and antibiotic administration. 1, do all patients screening positive for severe sepsis or septic shock have blood cultures drawn within 3 hours? So that could be a yes, they do. No, we don't have that process in place, and perhaps we have identified a gap. Or that could also be, I don't know, and I need to investigate more into that process. And later on in the presentation, I'll be showing you a process discovery tool that you can actually use to answer some of these questions. Second question, do all patients screening positive have blood cultures drawn before broad spectrum antibiotics? And third, did we start those antibiotics within 3 hours of presentation? Okay, next slide. Oops. Okay, so that document is actually kind of the precursor to this next document, which is a sepsis best practice diagram. Now, this was actually just released, and it's available on the Michigan Hospital Association community site for download. And this is a compilation of several best practices collected by the MHA Keystone Center from 2016 to 2020 surrounding the early identification and treatment of sepsis. Now, it's not intended to be a comprehensive guide. It's rather lessons learned that we hope through spread hospitals can achieve better outcomes for patients. And it outlines 6 crucial elements for an evidence-based sepsis program. And here is the first page. And again, it's very visual, and it breaks those elements that we've compiled from several sources into 6 elements. The first, multidisciplinary teams, early screening and diagnosis, antibiotics, fluids, hemodynamic stability, and of course, ongoing monitoring and communication. Now, this is only one page of several page document, but the subsequent information provided in this document gives a more in-depth explanation of the importance of these topics, as well as a variety of resources that you can use for review and reference. So as I said, the document that I just showed you was more the precursor, and this is made to complement that first framework. So when you are either looking at building a new sepsis program or looking at current processes and saying, what can we do better, you can start with that sepsis practice collaborative model as a basic framework, and then use this to dive deeper into the why and the how. And again, all of these documents are available for you for download on the community site. Okay, process discovery tool. So that's really just a nice word for chart review. I mean, the point of the process discovery tool is to gather a list of 5 to 10 charts, recommended that they were probably coded as either severe sepsis or septic shock. And what you're doing is you're going through specific chart items to look for common trends. Now, the nice thing about this process discovery tool is that it's real data from your organization. So you can use this to identify gaps in processes and then develop action plans to bridge those gaps. This tool was actually developed as a larger improvement sprint. You may have heard of some of the improvement sprints that we've done throughout the HIIN around readmissions and falls, but it can also be used as a quick standalone tool as well. So here is a quick snapshot of that tool. And as you can see, it's just basic questions from the chart. I have outlined fallouts in yellow, and I've just done that so that you could quickly look and see where are the best opportunities. And as you can see, 10 charts were reviewed and our attentions quickly turned to the item in most yellow, and in that case, it's the 3-hour bundle blood cultures within 30 minutes of positive sepsis screen and prior to antibiotics. Now, I do think it's important to note, there's multiple sources out there with multiple time frames. So CMS SEP1 measure says we have 3 hours for this bundle, but why did we put 30 minutes? A lot of the information that we actually have been disseminating is complementary to the Surviving Sepsis campaign bundles, which has taken a lot of those 3-hour and 6-hour elements and actually made a goal for 1 hour. Obviously, that's not how CMS abstracts those charts, but it is considered, the quicker the better. So when you see some of these 30 minutes or 1 hour things that you say, well, that might more so be CMS says that's a 3-hour, that's absolutely correct. We're just updating the most current timeframes to continually try to strive for quick sepsis treatment. Okay. The last item I am going to discuss is sepsis simulation. So we know that adults learn best by doing. The MHA Keystone Center from 2017 to 2019 performed 13 sepsis simulation events, and that was to give clinicians hands-on, real-life scenarios of performing sepsis care. 3 types of simulations were offered in various care settings: emergency department, care transition from a transfer from the ED to the ICU, as well as a general medical floor. And each scenario had objectives, there was observers, and we performed real-time evaluations of participants. We debriefed. It was very much created to almost do a code sepsis. These were led by our subject matter expert, Pat Poza, who is a leading subject matter expert in sepsis care and best practices. We received very overwhelmingly positive feedback from these events, and I believe in 2017 they started as just a couple of events and they evolved into a member favorite. So we actually decided to enhance the events to do a train the trainer, in which we were hoping at that point to take people that were interested in taking that framework of performing a sepsis simulation and bringing it back to their organization. And the whole goal of that was that if we could train 20 people, they can now influence and train potentially hundreds. Here is a picture from one of our sepsis simulations. As you can see, it's pretty realistic. It's in a controlled simulation lab, but it's almost like ACLS for sepsis. I can tell you that on the end of the member, I attended 2 of them myself, and I thought they were just absolutely fabulous. We are hoping to eventually bring these back. At this time, there is no official bookings for those, but it is definitely something that we would love to bring back in the future. Okay. Well, if there's any questions, then let me see. Is there any questions in the chat box, Naomi?
One second. So it looks like one question that they asked was, Just saying, great work. With the reduction in sepsis mortality, did any organizations see an increase in sepsis-related readmissions? If so, would those organizations be willing to share what interventions they have put into place to reduce their sepsis?
That's a great question. You know what I can do is that's a great question to also post in the community site. You could put that on there, and it's been actually very active with, you know, the pandemic and everything. There's been a lot of conversations going back and forth, and especially as quality work is starting to resume, I think that's something that we would want to definitely answer and address. So yeah, I will post that in the community site, and I will ping the person that asked that.
And another question, they're asking of where resources are located, and resources are located on the MHA community site in the Quality Initiatives folder.
Yes, and also if I can get the person that asked that question, I can send them a direct link to that. But yeah, it's the MHA community site. You go to your community, and at that point you can click library and all these resources. And we actually have over 400 resources that we've compiled over the past several years that are available for you.
Okay.
All right, excellent.
Yeah.
Well, then with that, I'm happy to introduce Ann Allen, who is the Clinical Quality Improvement Advisor at the Wisconsin Hospital Association.
Thanks, Josh. So sepsis mortality is one of the HIIN measures that Wisconsin did extremely well on throughout the HIIN. So I'm really excited to share with you all today some initiatives that our member hospitals used to really drive their improvement. Last fall, we held 3 sepsis improvement action networks, which are half-day events consisting of pre-work done by attendees, including a gap analysis. They come to the event with their gap analysis, knowing what areas they need to work on. An identified mentor hospital that has shown substantial improvement and sustained improvement in the area shares their story, and then spends time with the teams developing action plans for the rest of the time. Those attendees go home to their hospitals, they implement their action plan, they check in regularly with an improvement advisor over 60 to 90 days, and then meet back with the group as a whole after 90 days to talk about what worked, what didn't work, some other ideas for implementation, and future steps. So I'm going to share 3 specific initiatives from last fall that we identified. All of them focus on early recognition, early intervention, and communication. And then finally, I'm going to share our sepsis playlist from WHA's YouTube channel, which recently gained national recognition at this winter's CMS Quality Conference. So our first mentor hospital identified that they really needed to start screening all patients for sepsis and initiate that recognition earlier. So they developed a suspected sepsis protocol where every patient is screened every shift, so during the regular nursing assessment. And then if they are suspected of sepsis by meeting 2 or more SIRS criteria, the action plan is initiated. And that action plan consists of a nurse suspected sepsis protocol and cascades down, which I'll show you in the next slide. But the protocol follows through to severe sepsis and sepsis shock. All the way through, the patient can go back and forth between the steps as necessary, and this just served as an added reminder to nurses to do this every shift, what the SIRS criteria was, and that they were able to initiate the steps necessary after identification. So here is the protocol order set. And this is automatically ordered on every single patient in the EMR when they meet that SIRS criteria. It's nurse driven, so it eliminates the need to track down the physician and then convince them perhaps that blood cultures are needed or lactic acid or fluid bolus is needed. They can start all of this and then go find the physician, have that discussion. If the physician wants to discontinue any of these orders, they can. So it's also important to note that it's not overriding an individual clinician's guidance. On the back of the communication tool is the point of care tracking tool. So after the nurse initiates the suspected sepsis protocol order set, they start tracking their time for each one of these interventions on this paper form. What this does is it not only reminds them to make sure that they're documenting their actions in the EMR, but also that when the whole case is done, this goes to the quality department, the nurse reviewer, and acts as an audit tool. So they're able to provide the care team with real-time or close to real-time feedback. It also is used to abstract charts for the SEP1 measure for their CMS submissions. It's also within this organization has decreased the misses in the cases in transferring patients from like ED to inpatient floor or inpatient to ICU. The second mentor site last fall implemented a sepsis checklist, which is very similar to the communications tool and order set. Their goal was to provide more sepsis tools and education to their nurses. Once again, also focusing on nurse-driven protocols and the desire to initiate treatment faster. It also is used for tracking and reminding to document the elements needed for the SEP1 measure and allowed that real-time feedback to providers and nurses. These checklists got taken one step further in this organization into provider dashboards. The second priority of this organization was to improve their communication with their providers about sepsis and their performance on the sepsis measures. So every month, they give their providers their individual dashboard that you can see on the left-hand side, and is an example of one. It shows them how they're doing both positively and negatively in regards to SEP1. Helps identify where they need to maybe focus more of their attention to. It promotes discussion about case fallouts. They're given their follow-up cases with the medical records and the reason that it followed out, so then they can go back and do some looking. And then on the right-hand side, there's quarterly the department overall pass-fail rate that then their department team uses to guide their improvement efforts. And our third mentor site, they really utilized their EMR. And while this is very, like their EMR is Epic, so it's very Epic focused in this example, but we've found similarities in other EMRs, and we've connected organizations across the state to work collectively on those. So while Epic uses the Muse system, Cerner has the St. John's alerting system. So this information can be translated to other EMRs. So Muse is an automated data trigger. It gives patients a risk score, and it's constantly readjusting that risk score based off of the clinical inputs into the chart. The sicker the patient, the higher the score. And it's important to note that an organization can adjust the triggers and can also adjust the scores as to whether interventions need to be started. So this organization used their Muse scores that when the patient fell into the high risk category, those patients' charts, an alert was sent to the sepsis rapid response team. And then they start reviewing the chart in real time, notifying the physicians of any sort of things that are in their protocols that they would want to order or start. They review the condition at least once every 12 hours. It depends on what's going on clinically. And then all of that is documented in the chart for with the interventions and outcomes. They also did a lot of work on their best practice alerts. So here it's really, really key that you need to work closely with your IT department, and it's going to need a lot of tweaking, a lot of short rapid cycle PDSAs to get the best practice alerts to really work well for you. What they did was they used their CMS criteria for sepsis with revisions. They tweaked the SIRS criteria thresholds. They set it not to fire if they were on anticoagulants at the INR level, and also made sure that the MAP was auto-calculated into that. Then they also added additional criteria, BPA qualifiers and disqualifiers. For example, if a patient is post-op, it might get turned off for the first 8 hours immediately in the post-op period. Just trying to make sure that the BPA is not overfiring and your staff isn't getting alarm fatigue, but then also making sure that it is firing when we need it to fire and there's things that need to be done. So most importantly, don't use these things right out of the box. It takes a team dedicated to tweak until it's right for your organization. And finally, we have the sepsis YouTube playlist. WHA's quality YouTube channel has a sepsis playlist with 6 videos. Most of them are curated and heavily feature WHA's physician improvement advisor, Dr. Robbie Redwood. So it's really good content, it's relevant content, it's up to date. The first 4 videos are about an hour in length, and those are directed at anybody in quality who's abstracting charts, to nurses at the bedside, to physicians who are treating sepsis. The final 2, sepsis and the SEP1 core measure down coding and claims denials, and the avoid hydrophobia 30/3 despite comorbidities in sepsis. Those are more, those are short 10-minute videos that are geared towards providers. And it's really Dr. Redwood giving his personal conversation peer-to-peer that he does in person in his full-time job. And we've gotten really good feedback on both of those as far as providers listening to another provider and it opening their eyes to considering ordering the fluids even in CHF patients. So with that, I will ask Naomi if there's any questions in the chat.
We do not have any questions in the chat box.
Excellent. Then I am happy to hand it over to Adam Colris, the VP of Quality and Patient Safety at the Illinois Hospital Association.
Awesome. Thank you, Annie, and good afternoon, everybody. As Annie said, my name is Adam Kohlrist. I'm Assistant Vice President of Quality, Safety, and Health Policy here at the Illinois Health and Hospital Association. And so I'm going to go ahead and get my screen set up here. All right. Perfect. So I'm going to talk to you guys about a couple different concepts here that we've created through the GLPP HIIN that you all have access to. So these are available right now on our public-facing website. It's a couple things. The first is really a broader bucket of resources that we call implementation playbooks that we've put together. And then specifically, I want to touch on one of our most recent playbooks, the Journey to Sepsis Improvement, that I'll kind of walk through step by step with. Okay, so first and foremost, I want to talk about the implementation playbooks themselves. So I can give you guys a sense of kind of the background, where the kind of the best practices and knowledge are coming from. So you've got a very small ribbon graphic here that I know you can't read, but what I want to attempt to do is kind of walk through the broad pieces of each playbook so you guys get a sense of how these look. So when you uncover them, hopefully there'll be more value added. Because as you can see here, we've got a handful, about 7 playbooks that we've created over the course of the past couple of years in the HIIN. And the one that we're going to touch on today, again, is the sepsis improvement playbook. You can see that we've got plenty of other playbooks here that span the gamut of readmissions to C. diff to HAIs and social determinants of health. And so for some background on these playbooks, again, the ribbon on the right here is going to show you what they look like when you open them up. They're really just PDF documents that are anywhere from 7 to 12 pages. And these are end products of a program we put together called the Innovation Challenge. What we did in the Innovation Challenge is that we challenged hospitals in Illinois who had a best practice around one of our HIIN topic areas, which had 2 things in it. 1, proven reduction in patient harm, and 2, proven cost savings. We challenged those hospitals to come to the table and say, hey, would you be willing to link up with another hospital in the state who might be struggling with the same issues that you've seemed to master, and actually mentor that hospital over a course of a few months so they can embed the process that you've created, which has garnered you those results of reducing harm and reducing costs and getting that cost savings. And so that was the process that really bore all of these implementation playbooks. So we linked up several hospitals across the state on all these topic areas that you see listed here on this slide, and we partnered them together for the course of 3 months. So we spent a lot of time with the mentor hospital in the Innovation Challenge, really refining what their process was that garnered those results for them. And then with that mentor hospital, we really put together a playbook of how we could take all the good stuff they did and then embed it in a different hospital in a different part of the state with a completely different staff and culture and all that good stuff. And so as we were planning the Innovation Challenge, we thought, hey, this is great. We're going to have the chance to work at a high touch level with 2 organizations and to truly spread best practice. But then the big question we kept coming back to was, how do we make this spread even more exponential? How do we bottle that great work that we're going to find together between these 2 organizations that are working tightly together for 3 months? How do we bottle that together so that other hospitals on a webinar just like this could then take all that good knowledge and work and benefit from it as well? And so our answer to that was having these implementation playbooks really is the outcome piece of the Innovation Challenge. So as you look at this list of 7 playbooks and topic areas, know that there was a ton of high-touch work that happened in the trenches with folks at various hospitals over the course of a few months to create these playbooks. So So what I really like about these is that we're trying to make them as practical and pragmatic as possible. All these playbooks, when you open them up, they're going to look and feel and read more like a comic book, frankly, than an ARC guide to readmissions, which is 60 pages with 12 pages of appendices. Don't get us wrong, there's a ton of knowledge baked into these playbooks, but we wanted the aesthetic of them, the feel of them, to be something that you could give to someone either in a C-suite or at the front lines, and if they paged through it for a few minutes, they would kind of get the gist of the concept of what that innovation or that best practice or that quality improvement project was, and then they could recircle back with a multidisciplinary team and really dive into the playbooks in a meaningful nature. So these are meant to kind of sell you pretty quickly on a high level on what the message is, but then there's a lot of content detail baked into these that'll allow your hospitals to dig in. So the hyperlink here at the bottom of this slide is where you can go to access any of these playbooks. I will say the sepsis playbook that we're going to give a look at today is not completely 100% finished. We're still putting some finishing touches on that, so that playbook is going to be coming very soon. But what I want to do first, before we jump into the sepsis playbook itself, is give you guys a high-level view of what these playbooks in general look like. Because when I take a peek at the sepsis one, I'm really just going to hit on, for the sake of time, the high-level steps in that sepsis playbook. But I want to give you guys a flavor of how these other playbooks look and feel. So for all 7 of these, the very first thing we do is set up the stage. Who are the players in this playbook? Who are the individuals that made this happen? We give you an overview here on the left of what the steps are in the playbook, kind of how it came to be, and then we set up our cast of characters, right? So with this particular playbook, this was on readmissions, and we had an advocate hospital, a larger hospital in the Chicago area, who was kind of our mentor hospital. That was Dawn on the left. And then they spread this best practice to a small and rural critical access hospital in Southern Illinois, represented here by Jennifer. And so we really like to kind of set the stage and tell that story up front. So there's a bit of introduction in each of these playbooks, and then we set up the challenge itself, or the best practice, if you will, which we're kind of using interchangeable here. The best practice with this particular playbook was reducing ED recidivism and unnecessarily hospital admissions and readmissions. So we give you some high-level background, why this work was important, and then a very high-level graphic or overview of the innovation that we're going to dive into. And for this readmissions playbook here, it was the ICP, or the individualized care plan. Now, I want to point your attention to the middle of the screen here. This is the juice, as I call it, with all these playbooks that you're going to see with all 7 of these. We don't just tell the story of how hospital A did this and then what their advice was to hospital B, but we bake these playbooks full of a lot of the resources that hospitals either built while they were implementing these best practices, or that the spread hospital revised and changed on their own to make this stuff happen. So I would definitely call those out as some of the best gems of all these playbooks are these little icons that you'll see, which have different elements that you can click on so you don't have to reinvent the wheel. And then finally, it's the playbook itself. So with each of these playbooks, it's a step-by-step, very linear process that we outline. You know, some of them are steps 1 through 6, others are 1 through 9, others are 1 through 5, but you get the idea there. And then this playbook was our HIIN huddle playbook. And on the left, we always have our cast of characters who are kind of telling their story. This was Dr. Alfredo, who was kind of our mentor hospital here, and then on the right was his spread partner. But you can see on the steps, we always do a few key things. We talk about the key activities within that step that would have to happen, some of those keys to successes and challenges, who was involved, and then again here at the bottom, any of those relevant documents that hospitals would need to kind of operationalize that step. So on a high level, that's how all of these implementation playbooks are laid out. Telling you the story, who was involved, what the challenge or the innovation was that we're bringing to you, and then what the steps are that you would need to take to implement that at your organization. So with that overview, again, in the sake of time, I'm going to be brief with diving into the sepsis playbook, but I want to give you guys the broad strokes and an idea of some of the great work that our HSHS system has done with this playbook. So this started in our Southern Illinois division of HSHS, and it's been a process that's been in place for some time. When they looked at the numbers in Effingham down at the hospital, they realized that mortality was really going the wrong way. Sepsis bundle compliance was a big issue, and folks were frankly losing their lives. And so there was a burning platform there with their local data that really drove them to revamp their sepsis implementation bundle. And so you can see some impressive results since 2014 that they're boasting with the improvements in their mortality rate, the huge jump in the bundle compliance that they realized, as well as all the lives saved. And there's some nice documentation baked within this playbook that you can access that gives you the background and really shows you where they went from bundle compliance and mortality rate. So the outcomes are definitely here within this best practice. And then what we jump into are the steps. So this is really a 5-step playbook. Again, this one it's not as polished. There's some more documentation that we want to add and some more commentary from some of the folks that were involved with this team. But one of the characters that you're going to see throughout this playbook is Dr. Jennings. He's the Chief Medical Officer at the hospital here. And again, the first step, like any improvement teams, is assembling the right team. Critical here to get our champions in place from the quality, physician, and nursing perspectives. Also getting those multidisciplinary teams in place and having regular meetings. So a lot of this stuff, if you've done any improvement projects, this first step is going to be very similar, and most of the resources we're going to bake in here are similar. So the second step that we're going to get into here is developing the tools. And this one I really think has the most meat on the bones, if you will, across this whole playbook. You can see in the bottom right-hand corner there are all these great resources that we're going to bake into this playbook that the hospitals, either HSHS created or their spread hospital created. So everything from the screenings that they're using on a daily basis, to their tick sheets, to the sepsis algorithm they put together, as well as the order sets that they baked in. And, you know, a big point that we kept reiterating here was that handoff between ED to inpatient. And they've got some really good language and tools around that. And a big point of this step was just highlighting how critical it is to have an IT champion or decision support champion on board early, so you can ensure that you're streamlining and building in all of those order sets and screenings into your EHR to ensure that we're streamlining that process of care delivery for the clinicians. So the third step is education. Again, won't spend a lot of time on this one. This is an obvious one for our improvement projects. Once you get the team together and once you have your tools together, how do we educate the staff? I will just highlight the bottom right-hand corner. That document there has been amazing. They gave us kind of all their PowerPoints that HSHS used to train their frontline staff and to educate folks. So that's a wheel that you won't have to reinvent, and the competency of those PowerPoints is really nice. The fourth step is implementation. So kind of where the rubber hits the road there, critical to look at your baseline data and get a sense of where your local gaps are. There's a nice spreadsheet that HSHS used to record their fallouts, so they could really pinpoint from a sepsis bundle perspective where they needed to focus on early and often. And that was really a critical step of implementation. And then our fifth and final step here is tracking and monitoring. So just again, reiterating a lot of continual feedback on the tick sheet from frontline staff. So there's multiple versions of these tick sheets and order sets that HSHS used over the years. And the more that their frontline team used it, they said, hey, we could tweak this here or there. This doesn't make sense. So we'll include those versions. But again, a lot of continual tracking and monitoring, real-time feedback from your abstractors was a big thing. And then again, there's a few really good resources on this page. One is their Pareto, kind of how they track their data, so you can get a sense of that, along with some of the physician notifications and educations they use to communicate this to the physician staff. And so the last slide, as I kind of fly through here, is going to be something that's also baked in to all of our playbooks. We know that you guys haven't had the luxury of stepping through this process like our hospitals have for 3 months. And so we set you up with a little tutorial on how you could take any of these playbooks and do a 60-minute implementation session with a multidisciplinary team. And so there's a design canvas that you'll see here on the bottom left that you can download and print out. And it basically is a nice roadmap for you to take the playbook, digest it with your team, and then figure out what resources you need, what bold steps you need to take, what your individual goals might be. Let's say after you look at your bundle fallout compliance and you say, hey, this is the area where we need to really focus on, making your own kind of vision and strategy canvas of how you want to take this playbook and use some of that knowledge to enhance your process at your organization. So this is another kind of nice way that we end each of those playbooks. And again, I apologize that I've been short on time, but I flew through that. But with that, I want to go ahead and pass it back to Naomi and let us see if there's any questions and wrap us up. So thanks.
Thank you so much, Adam. So we do not have any questions in the questions box. And I just some last minute reminders. This session will be recorded and the slides and recording will be posted on the MHA community site. We also wanted to remind you that the next webinar will be on July 16th, where we will be sharing best practices and resources that can be utilized to address healthcare associated infections. And if you have any further questions, please reach out to keystone@mha.org. And with that said, we would like to thank you all for joining us today, and we hope that you have a great rest of your day. So thank you, everyone.